advisory council members we have. I'm going to call the names of folks I've seen, and then if anyone is looming in the 17 people that are out there on the phone, if you could just unmute yourself and announce once I read these names, I'd appreciate it. So I see joining us today is Scott Rose. We have Kim Okiki. We have Kevin Hayes, Robin Elliott, and Brett in for Bob Atlas. And then you can see the leadership team, Ben Steffen, our executive director, Dr. Haft, who is the executive director of the MDPCP. Staff here is myself, David Sharp, Melanie, and we have Alana. And then behind the scenes, we have Anani, who's working the technical challenges. Can the folks who I have not called their name that are on the advisory council, please take a moment to unmute yourself and tell us who's there.
This is Scott Rose.
Scott, good afternoon. Thank you for joining us. Who else?
Bob Berenson.
Dr. Berenson, how are you? Thank you.
Thank you.
Anyone else from the council?
Hi, it's Patrick Dooley.
Patrick, good afternoon. Thank you for joining. Anybody else? Okay, so we will just sort of give you a highlight of what we're doing today. Melanie, can you talk a little bit about the process?
Sure. Can everyone hear me?
Yes.
Okay, great. So this, just to remind everyone, the meeting is being recorded. Please contact Anana or Melanie, or you can send a chat message if you're having any technical issues. So you can mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. Please remain on mute when you're not speaking to reduce the background noise. Staff may mute you if there's a lot of background noise coming from your line. You can always unmute yourself. So you can only use the chat function to send notes to all attendees. This technology does not allow you to send a chat message to specific attendees. Please announce yourself when you're speaking. And since there are a lot of people in this meeting, we'd like to sequence the speakers whenever possible. We understand that there's times when people will want to speak and they don't necessarily have their paper up, and that's absolutely fine. But if you would like to speak, please signal to the team in some manner. One manner that we use is you take a piece of paper, you fold it, and you hold it up like that, and then the facilitator will call on you. So the facilitator will also be calling on people to ensure that we have a wide range of perspectives. So we may be calling on people who don't have their paper up as well during this meeting. So that's all I have at this time. So David, I'll turn it back over to you.
Yeah, and just real quickly, Ben, any opening remarks from the MDPCP?
So I think we want to use the time as efficiently as possible. No one will benefit from any time spent by me. So go ahead, David, run with it.
Sure. So joining, I saw Gene Ransom with just one last check. Anyone else that is not from the advisory council that did not hear their name mentioned, if you could unmute yourself and let us know. I see Dr. Barr has joined us. Thank you for joining. Anybody else?
David, this is Laura Goodman from Medicaid. I'm on for Tricia.
Hello, Laura. Thank you for joining us. Okay, Dr. Haft, any comments you were going to make? And good afternoon, Will. I see you're here, so thank you. And I think we lost Dr. Haft somewhere.
No, I'm here.
Okay.
So thank you, David. I'm here, and I want to thank the advisory council members, as always, for their participation, their deliberations, and this is very important work that we're doing in creating a path forward for the way we deliver and pay for healthcare in the state of Maryland at the primary care level. There's probably no more important work that we could be doing at this time, and I think over the last month or 6 weeks or so that there's a few things that we've already established that are, I think, are very important and directionally correct. That phase one of the MDPCP is something that will naturally and appropriately be phased. I mean, track one will naturally and appropriately be phased out over time, which is a big move. I think we also have established, and I think in a very appropriate way, that we will have at some time in the future an option of track 3 that will be very inclined to population-based payments and because now we recognize, after having lived through and continue to live through COVID, that the vulnerability of the fee-for-service payments are very significant and not resilient in this and probably in other times in the future. So I think we're committed to moving to population-based payments and some version of a flat fee to continue to incentivize face-to-face visits as they're appropriate. I think those are major strides forward, but there's still a number of things that need to be resolved and within this constructs, those broad constructs. I'll turn it over to Michael.
So, Dr. Riedman, before you start, just want to say hello to Dr. Pham. She's joined us, and Mike, Dr. Riedman, if you want to say a word about the modeling as well, that might fit. So, please proceed.
Okay. Welcome everybody. We're in the interest of time, I'm just going to keep moving. We're going to go use the same format we used last time with going through our template. I did want to start off with a comment that our time frame has, as we've gone through this, we realize the time frame is having some significant and meaningful suggestions to CMMI, CMS by technically next week is just not practical. A lot of appropriate questions came up last week. I'm sure going to be more questions tonight. And as we've gone through this, we realized that the time crunch of getting this done by even the next month or so, I don't think it's practical in light of COVID, pushing us back 4 or 5 months. So even though we're going to try to get through the process as efficiently as we can, I want everyone to recognize we're going to really push it back and try to make suggestions strongly to CMMI that we need to have more time to give any kind of significant and meaningful suggestion to them. And then for something this important for us to push it through and try to give them some preliminary suggestions in a week or two, or even 3 or 4, I don't think it's practical. So I want to reassure everybody that we're going to listen to what everyone has to say. We're going to need to get some more data together for future meetings. We're going to push back on the timeline, which technically will sometime next week. So I just want to make sure everybody's clear on that, and we'll bring it back and we'll let you know what CMS feeds back to us. William, Will, you had a question, or I'm sorry, you raised the magazine?
Yeah, I was just curious what CMMI would say about that. I think we sort of got the impression the timeline was important to them, but so I'd be curious as to what CMMI thinks the implications of us delaying are.
Dr. Hatt, can you answer that?
I couldn't hear very well what Will was saying. If it's what CMMI would say to extensions, I think they have a sense of that to get something through by 2022, that there's a sense of urgency, and for 2023, I would anticipate less urgency for a year further down the road.
Well, I guess the question, Howard, is were they pushing to get it done by 2022 for any particular either political or policy reason? And what are the consequences of us not following that timeline?
I can't, they haven't shared any of their political influences with us, so I don't have an opinion can't give any insight into that. And I guess the consequences are the consequences as described in our contract, if we fail to meet certain covenants within the contract. But I don't anticipate that we'll be able to meet any of those covenants, but I think time will tell on that.
So I think Stacia had a question. Good afternoon.
I did, and I guess it's a tag-along question to the one being contemplated here. It strikes me that we've heard a lot of concern about the challenges of continuing to be completely on a fee-for-service architecture and not moving into population-based payment in light of the challenges primary care has had with the COVID environment. And it feels like a lot of opportunity for us to move to population-based payment if we can't get aligned around a path forward here. That feels like a real risk.
And our executive director, Ben?
So, be sure I'm sympathetic to both Will and Stacia's points, but I do hearken to the old health policy analyst adage working fast takes time. And I think we're at a point where we really, and the idea of the advisory council was generated from within MHCC. And I think we're at a pivot point that the only way we could conceivably meet some of the earlier deadlines that were announced to us this summer was to completely abandon the advisory council process. And I think the leadership, Howard, David, Dr. Reitman, are of mind that this input from the advisory group is very important. I'd note that in the meetings that I have sat in on with the CMMI team, they are really respectful of the input from the advisory group. So short-circuiting that to meet a deadline may not yield the result we hope for, but I think it does emphasize the importance of this advisory group being very thoughtful as we move as quickly as reasonably possible to get a preliminary set of recommendations put forward.
So any other comments? Gene, I think you've joined. Any reaction? Gene Ransom?
There we go. Sorry, I was muted. No, I just want to say that I think that it's more important to do it right than it is to do it quick, and we can figure it out. I think it's important that we clearly communicate to CMMI that we want to have a track 3 and we need to move towards more risk and more value-based. I'm excited. I understand that the HSCRC has a plan to start moving us in that direction on their agenda tomorrow, and that seems to me that maybe that could be an initial track 3 response, and there might be other ways to do it. But the problem is if we move too quickly and we do it wrong, we could create a complete mess. So it seems to me that we can reach some kind of reasonable balance and keep the ball moving down the field without fumbling it.
Thank you. Will, I think you had another follow-up comment.
Yeah, so I think all that makes sense, and obviously I think it's better to do things right than fast. I guess the question, though, is why was CMMI giving us a deadline of next week, and what are the consequences of not meeting it, right? And so, as an analogy, if I were in college and trying not to submit a term paper on time, I would want to know what's going to happen to me as a result, and it makes me a little nervous that we don't have any sense of why CMMI is saying we want to do something by this time period. And it seems like we're only partially informed.
Did I miss a letter or a contract term or something? I read the contract again recently, and there's no timeline about this in track 3 in the contract. Did we get a letter from CMMI or something? Or everybody keeps referring to this magic deadline that I'm confused.
Dr. Hatt, explain how the policy discussion evolved.
So I think it's something internally that related to kind of the CMMI's general direction for the country, and that they've made a broad policy decision for the nation to abandon CPC Plus and move to primary care first. That was the brainchild of one of the prior CMMI directors, Adam Bowler, and I think we're being swept into that stream of let's make everybody move from wherever they are to primary care first. They're doing that with CPC Plus, and I think we're getting swept into that. And there's also some, this is a political season, obviously with an election. I don't doubt that at any time of the year that politics play a role. So I think even at this time of the year, it probably has also some influences. As the potential of changing administrations looms over people, it looms over people. I'll stop there.
Dr. Pham? Thank you, Dr. Hatt.
Yeah, I was just going to ask about whether there's a potential middle path, which is, on the one hand, could we just ask CMMI to clarify what happens if we don't have all the details by this first milestone? And on the other, can we just figure out at what high level of content we can submit, still look credible, but not take on the task of having thought through every last T to be crossed and I to be dotted? by then, and then presumably there will be other milestones where we can finesse things. I don't know. That would have been my expectation, but
Dr. Happ?
are those in the past?
So, no, I think that's a very good idea. I think submitting, if we can come to some reasonable conclusions on the 8 or 9 things that we still need to resolve and make a policy statement without detail, I think that that would certainly be a middle ground.
So I would suggest we go ahead and move on to our agenda for the night, but and leave this conversation with basically the fact that I think we keep moving forward with what we have right now, which is our deadline. If we get forced to make some input before we're ready, then we do the best we can with what we have. We'll try to get through the most we can tonight, and then hopefully the latest decisions so we can give them a more realistic and much better thought out suggestion. Just some of the issues that came up last week, which I'm talking, maybe Alana can pull up the template, but just a suggestion came up last week, brought up a lot of questions that we really need to think through and model out more before we can make a really important and meaningful suggestion. So, if they insist on what we have now, we'll have to give them what we have now, with stipulation that this is preliminary data. And I can't speak for the CMMI, but the world is still on hold for COVID for all of us, and I think this decision, which is important, and also may have to be postponed. So we'll move forward on the assumption that the timeline is what it is, but hopefully we can get some movement on that. So,
and Alana, can you size just slightly for everyone, please? Increase. There we go.
Okay.
So are we allowed to ask for an extension?
Gene, Dr. Haft?
Yeah.
So Gene, yes, we the deadline was that they originally gave us was the end of August, and so the deadline was longer originally. Then it became the end of August, and now it's September 4th, so it's a week from Friday.
Okay. Alana, would you scroll up to number 1 real quick? So I just want to really read through this quickly, but just so everybody remembers where our conversation was. That's that third white column. There's a white column, a turquoise column, and a white column. I just want to make sure we read through that, and then we'll move on to the other 2 main agenda items we had in the final one. But if everyone remembers our conversation last week, we the flat rate, you can read that, but it said reflect the current CMS fee schedule, match the level 3 in visits, fee at the year of implementation, and increase annually the same rate as the UNN code. Fee schedule, the flat rate is not reflective of the actual cost of care. We had that conversation. The increase to the PBPM and the raise the payment ceiling overall, that we talked about, increasing the PBPM. We need data on that. We had talked about that last week. Ensuring incentives is designed. Ensure the incentives are designed not to reward providers for avoiding treatment of high-risk beneficiary visits. The financial modeling, compare the payments at track 2 and 3. That was one of the significant issues that came up last week. Scrolling down a little further, the simplification of the formulas and reduction of administrative burden. We had a conversation about the downside risk for practices in high-risk communities. Could be a barrier to participation. Practice assessment of technology and HR. We had a significant conversation about that. The PCF, Patient Care First, requires practices to have 2015 cert, and all MDP practices currently meet this requirement, but functionally there's a lot of variability. The need for budget neutrality should be addressed to ensure the bonuses for primary care practices do not have a negative impact on the overall total cost of care. And then referral rates may be more accurate than hospitalization for measuring cost of savings. If we have the time, hopefully we'll be able to double back to this and the other agenda items in our future meetings to kind of address some of these issues. But that was the bottom line for our conversation last week. If anybody has suggestions or different thoughts, I think we got something wrong, just after the meeting, if you'll email one of the either David or I, then we can address that. So moving on to the night's agenda, item number I believe it's 5 on our list here. We're going to skip a couple and come back to them, but we felt we would address the 3 top ones as we talked about before. And The next one would be the performance measurements. You can all see there that the primary care first program, the measures were selected to be actionable, clinically meaningful, and then the quality, and then aligned with CMS's broader quality measures, and you can read that part. Our group, the subgroup, that's in the turquoise. Can you move up just a little bit along the first? Yeah, the quality and utilization measures would be the same for all track 3 practices and not separated by risk groups. These measures were selected to be actionable, clinically meaningful, and aligned with CMS and Maryland's broader quality measurement strategy. The measurements include a patient experience survey, controlling high blood pressure and diabetes, hemoglobin A1C, and poor control. The utilization measures for the PBA calculation and the PQI hospitalization and PQI ED, the ER utilization. The quality gateway, patient experience and comprehensiveness of care survey selected by the state to include a tier 5, which we have 4 tiers, and the question about a tier 5, which is the SIP, which we'll discuss also in a few minutes, comes up. And then the hemoglobin A1C port control over 9, you can read those, and the MIPS controlling high blood pressure and how that's defined and agreed upon by the state and CMI subject to annual review and modification. Then we had the risk, group, the risk 3 to 4, which really wasn't applicable with what we had talked about. You can see what the primary care first program suggested. And I think there's one more item down. Hold on, is there? No, that was it for that. So I'll open up discussion about how we should measure quality and suggestions that people have, and whether that's what's appropriate to measure quality and how best to do that. I'm going to tell a very brief story I told to the subcommittee. I'll make it even shorter, but and this is not a unique situation. If it was, I wouldn't bring it up. But I had a patient who has terminal pancreatic cancer recently, came in the office. His A1C was higher than it should be by the quality measures. His blood pressure was a little bit higher. Came in for his annual wellness visit, but asked me a favor before the visit if I would look at something for 5 minutes with him. And ended up, I spent about 15 of the minutes with him for he had his family, because he had no funds, had paid for him to go back to his home in Holland that he hadn't been to since he was 12, and sent him on a trip down a barge with the rest of his family, and had a wonderful time. But what he pulled out of his backpack was a photo book, beautiful photo book done of his trip, and we spent 15, almost 20 minutes just reviewing the pictures and talking about it. And at the end, he said to me, Dr. Reedman, this really meant a lot to me. And I looked at him and said, it meant just as much to me. And the day I can't do this kind of thing is the day that I'm not doing medicine anymore, because that's why I do it. However, when I walk out of the room, I realized that we really never got to his annual wellness visit questions. His A1C, which was out of control for terminally pancreatic cancer patient, doesn't have any meaning. His blood pressure was a little bit elevated, which again has no meaning, but we didn't address those things. And the argument is, how do you measure quality when the quality measures aren't, and it's a population, you can look at that, but that patient's not a unique patient. Every patient's unique. And so we're really measuring the right thing when we're looking at specific numbers and how best to do that. So again, I'll lead with that story, but I think that opened up our conversation at the subcommittee, and I hope it opens up the conversation tonight.
Yeah, and I would invite Dr. Berenson to make some opening comments, and then followed by Dr. Barr, who joined us as well. So good afternoon, Dr. Barr. Dr. Berenson. And you're muted, sir.
I unmuted the wrong symbol. A few weeks ago, I tried to argue that we could be more creative with quality measurement and also include quality improvement as part of the quality agenda. I'll just repeat the major point I was making is that I think in the last few years there has been a significant research. There's been significant research showing that tighter blood pressure control results in significantly improved outcomes, and that the current standard may be outdated, the standard that this would be. And so it's sort of a process point, is that should we have the opportunity for reviewing measures and maybe being a little more assertive about updating measures. I do understand that. Well, actually, what I was going to say, I do understand that that a measure for this purpose might not be to get the ideal blood pressure rather than a minimally acceptable blood pressure. But there's been so much in how we should measure blood pressures, what the goal should be of treatment, that I think it deserves a review. I'm not going to argue here what that review should result in, but I just think that a lot of measures that we're being asked to accept are outdated, is I guess my basic point.
Yeah. Stacia, and then I'm going to go back to Dr. Barr afterwards. Thank you, Dr. Berenson.
So I would just comment that one of the other things we talked about in the subgroup is that multi-payer alignment is really important. So deviating from standard measure sets guarantees that you are not going to get broad multi-payer alignment, because that's not how quality is measured for the rest of the payers. And so let's not forget that if ultimately what we want to do is reduce burden in primary care around quality measurement so that everybody is working on the same kinds of measures to move the field forward, while they may not be perfect, we still need to have measures that other folks can align to.
Yeah, thank you. Dr. Barr, comment, please.
Actually, that was a perfect segue to what I was going to say, because I do think this has been a tension among the subgroup in terms of how much creativity we can bring to quality and measures, and how much we need to, as Stacia said, sort of make sure we don't create unnecessary burden. I think there may be a little bit of both potentially. I think we should think about that. And yes, use the measures that everybody's using, because you don't want to create unnecessary burden. But as part of this, really look creatively at everybody's using a certified EHR. There are data out there that people are doing. You have CRISP, you have an HIE. Other opportunities to, behind the scenes, without creating other unintended consequences of burden, look at different kinds of measures or improvements to measures with measure developers. And of course, I'm a little biased being from NCQA, to kind of look and see how we can get to better quality measures and drive quality without kind of layering on more requirements upon practices and those who are doing the care.
Yeah, I think Dr. Haft and Dr. Berenson.
Yeah, I agree across the board. I think that by principle, the issue with the quality measures is that as designed in primary care first, it's the federal government that makes those calls. And I think we've worked very hard to establish that in Maryland, we can design, and it could be very much multi-payer alignment if we can do that in an efficient way, and I think we can. But we should here state that by principle, it is that Maryland, the state, together with the advisory council, should establish the quality measures, how they affect the performance bonuses, and also and simplify them. I think, and simplify them significantly. In primary care first, it's a quarterly reconciliation. We all felt the pain of what annually reporting quality measures means. You can only imagine what quarterly reporting would feel like. So I think by principle, it's just that the state would not accept CMS's division of and the way that they do quality measures, that we would want to keep that in-house and make those decisions ourselves.
So thank you, Dr. Haft. Dr. Berenson, and then Dr. Okiki, we would be asking you a question, and then Mellon follow.
Well, Dr. Haft basically said it better than I was going to say it. I think I didn't recommend that we adopt our own unilateral measure for hypertension. I think we need a process which is a multi-payer process. I don't think Care First wants to use outdated measures either. In fact, the challenges of aggressive blood pressure treatment are tougher in Medicare patients than they would be for a commercial population. The current measure is not appropriate. So I'm suggesting that Maryland should, a multi-payer approach for Maryland to improve the measures. That's what we would want to, we should be seeking a Maryland process.
Thank you. Dr. Okiki, then Melanie, and then I think Dr. Pham.
Yeah, I would echo what everybody else has said, but also something to keep in mind is the timing. Because from the previous conversation we had about the BPA that has the quality gateway that ties into this, for the first year, I believe you were not supposed to calculate the, I think performance was only for utilization. And then by the second year, they were now going to include the quality. So I found that kind of backwards because utilization, is driven by, health outcomes. So hoping that in somewhere in our response, we do make sure that we speak to the health outcomes and the focus on quality measures first, or in alignment with quality from a performance perspective. And yes, as we said, some of these measures are not, I guess, measuring the right things, depending on what patient we're talking about. So also leveraging what already exists makes sense, not to reinvent the wheel. But I think something else that I know that Dr. Haft and the Hilltop folks have worked a lot on is the influence of social determinants. So knowing that for each patient, each case, ignoring the underlying social determinants or barriers to care and how that impacts the outcome is also something that we haven't drilled down into as much to really define at a level what the primary care provider can control. I think that's another way we could look at defining outcome measures by patient cohort.
So, Alana, just an adjustment. I think it's use quality measures in year one and also consider social determinants of health as well, and not necessarily intake. We can take the utilization off of that for a moment. And then I think, Melanie, you had a comment?
I just would like to invite Dr. Berkowitz and Patrick Dooley and possibly Jean to weigh in from a CTO perspective on collecting quality measures, because they've worked with many practices and trying to get this information, and maybe they can give us a little bit different view on the practical side of collecting and reporting on quality measures.
Very good. Dr. Berkowitz. And I think we actually lost him. I did see that he left.
Oh, okay. My apologies.
Patrick, you may have us on mute.
Yep. Okay. Can you all hear me?
We can hear you now. Please proceed.
Great. Okay. So I think the way I think about this is, while I think there needs to be a larger conversation with CMS and the payers around changing some of these quality metrics that may be a little outdated and are in need of reform. I'll admit I do share Stacey's concern about picking a quality measure that would be so unique to this as to inhibit kind of alignment across the payers. Because I guess to me it's what would the primary care providers that we work with prefer? Would they prefer one program that has a set of measures that are kind of unique and maybe more germane to the work that they are doing? Or would they rather have a series of measures that kind of are better aligned across all of them, even if they aren't necessarily the best measures that one could hope, while we work towards kind of a longer term strategy of how do we really reform these measures to make them more primary care focused, that really rewards kind of the good work and the good behavior that Dr. Riedman and others have commented on. So, I really kind of splitting my answer here, but I think in the near term, coming up with unique measures that don't have broader buy-in from the payer community in some ways could inhibit overall what's trying to be achieved. But I absolutely agree with the longer term premise of how do we work on these measures so they're better aligned with what ultimately we're trying to measure.
Yeah, that's a good point. Jean, I know you said the internet was unstable. I'm not sure if you were able to join us back. And you might have us on mute. Okay.
I think we have Debbie Kuchka-Craig on. I saw her name on the list.
Yeah.
Maybe she could weigh in from MedStar perspective.
Yeah, I would echo the need to ensure as much consistency as possible, with recognition that, there could be differences for a Medicare, Medicaid, and commercial population. The other thing I would just say is I'm always amazed at the fact that the measuring quality from purely claims data doesn't often tell the whole story, and how important it will be to ensure that when we're evaluating quality, we're incorporating what's in the electronic medical record as well as what's showing up in claims. There's always a bigger gap than one would expect.
Yeah, thank you. And I think Jean may have come back. Did we get you back, Jean? And if not, Dr. Pham?
Yeah, I am. I'm on, but I have no additional comments. What the doctor said I would agree with.
Okay, thank you. Dr. Pham?
Can I just ask for clarification? Several comments ago, I couldn't tell if I was hearing that what we were proposing was potentially a multi-payer process to review the metrics as a long-term strategy that would involve just Maryland, where we were proposing that primary care first engage in a multi-payer process to review metrics as a long-term proposition with Maryland as a part of that. Which is it?
So, Dr. Riedman, I would say I was hearing that it was more Maryland as opposed to primary care first, but I yield to you.
I think that's what we were talking about. Yes. Howard did.
Okay.
Yeah.
But not.
Yeah, Maryland is. We've been active participants in creating aligned with our state health improvement goals and our population health goals, creating the quality and the influence of quality on payments, and we just would want to reserve the ability to do that.
So the measures would be determined at Maryland and not as primary care first, allotted just for the notes. And then Dr. Berenson. Thank you for the question, Dr. Pham.
Yeah, no, it's a good question. I think it would take a lot of chutzpah to think that Maryland is going to tell the CMMI will help to change their measures. But if we actually do a good job for Maryland, they might learn from us.
Well, I was thinking more, Bob, just that, I mean, chutzpah aside, even if it's just a Maryland process, CMS would have to be involved, right? Representing Medicare. And they have shown no inclination to engage with other payers in the design of anything related to primary care recently. So I'm just offering the question, how realistic is it?
Well, I guess that my response would be there is some in the distant past. CMS was quite responsive to working in the medical home demonstrations. Medicare was a very good partner with private payers, and there's a possibility that there will be some personnel changes with CMMI next year.
Dr. Barr, any last word on this before we turn it back to Dr. Riedman?
No, sir. Thank you.
Okay, we're good. So as someone who was raised on chutzpah, we can keep moving on. So our next item, which we kind of touched on last meeting, was really the issue of the track 3 and whether that track 3 should be mandatory, voluntary. If it is mandatory or even voluntary, should it be a phased-in approach where, especially if it's mandatory, we have a phased-in where, the risk is downside of 5% instead of 10% the first year, and maybe goes up to 10 and maybe goes up to 15 or 20 as time goes on. And the same with the upside, we have a graduated increase in the risk versus the first year. It's I think the numbers here were 35 up and 10 down. And then there was the issue about the availability of the SIP, which is highlighted there. I didn't forget to talk about it. I think the big question here was whether it was that the track 2 should stay in place and make that mandatory, but track 3 would not be, if it was, when. For the smaller group, I've mentioned a number of times, our group certainly is more capable than most because of our size and our administration to move to a track 3 faster than some. But for the smaller groups in the state, I think making a mandatory track 3 puts them at too much risk for something that we all have to learn how to do also, especially if there's a time frame that's in the next 2 years or so. One of the physicians I think mentioned in one of our early live meetings, which I thought was a really good point, was that we're learning how to do this. The primary care physicians we didn't get a training manual. We didn't go to med school for this. Our group has administrative help for it, but physicians have to learn how to do this. We have to learn to manage these people. So to push them too quickly into a mandatory track 3, I personally think is a setup for failure. And I know that that's important. I know we need to reduce costs, but again, I think that the conversation today should be, I think that'll introduce it to whether it should be mandatory, and if so, when, and what does mandatory really mean. So I'll open up the floor for further comments.
Dr. O'Keefe, Kiki, comments?
Yeah, sure. I agree with you. I guess the question would be, how do we define smaller practices? Is it the number of practitioners? Is it the size of the patient panel? Is it advancement in care transformation capabilities? So I think framing what smaller practices, or quote unquote, would I say middle performing practices, a better way to frame that would be good, so that way we are clear about who is optional to stay in track 3 versus those that quote unquote may be mandated to move on to stay in track 2 versus those who will be mandated to move on to track 3.
Dr. Reedman?
Yeah, my thought there would be that if we're going to make it mandatory or voluntary, I speak for my group, but there are a lot of groups that are our size that still don't have the manpower and the ability to move necessarily to track 3. So I'm not sure. I know the smaller groups would have a harder time, but I think even for some of the larger groups, again, it's making it mandatory at too rapid a pace may be a problem. So I would say that rather than the size of the group, I think it may have to be something the groups look and see what they truly and realistically can do. If the upside is enough, the groups will move toward that. But I think that more the size of the group would be I don't want to say it's sophistication, but that's probably the best word for it, of the groups and whether they can and can't do it.
So thank you. Will, and then Stacia. And Will.
Yep. Thank you, David. I think at least to my mind, the question of small practice bearing risk, I think can't be disaggregated from the question of the CTOs and what role they play in the system. And I think when the program was initially designed, there was a recognition that there would be resource difficulties for very small practices, and that the CTOs were an attempt to provide some economies of scale in order to help out. I think if there were mandatory downside risk, there's potential for the CTOs to play a risk aggregation role and sort of shield some of the small practices from, sort of the eccentricities of the downside risk.
Thank you, Will. Stacia, just your thoughts here.
I'm interested in Will's perspective about that. Might we be suggesting then, if the CTOs are going to be an aggregator and take on more risk, that they actually get more of a share of the primary care fee, the care management fee? Because otherwise, who would do that?
Thank you. Brett McCone for Bob Atlas, any comments? And then we'll come back to afterwards. Then Debbie, let's go to Brett and see if he's there.
I'm here. I think, in listening to the conversation, I think that the concern, at least I would have, is what will CMMI's view be of sort of the mandatory move to the track 3, to the risk bearing, and how will that affect our overall cost of care? So how will they view the physicians taking risk in terms of our overall contract? I don't necessarily have an opinion on the CTO as the risk-bearing entity. I think it makes a very good point that the function of the CTO is to aggregate that risk. But I do agree that with Stacia that, unless there's a larger share in that aggregator and take the risk, and you're going to offload that to practice, it would be tough to do that without a chance.
Yeah, good point. And thank you. So Debbie, and then Patrick, if you could be prepared to weigh in.
Yeah, I just find it an interesting time to have this conversation, because I believe we just this week or late last week received some of the additional questions that the practices need to answer in order to determine whether they're ready for track 2. And I was just curious as to whether anyone, in their crystal ball had a sense of, what would 2021 look like in terms of the percentage of practices that are in the program that will be accepted in track 2? Because I think that informs us about readiness for going to track 3 if it's supposed to be a progression. I think it's very, very hard to talk about anything that would be mandatory before we see how the whole landscape of the state lays out for track 2.
Very good. Alana, you'll capture that point. And then I think it would be interesting if we ask some of our consumer reps, Robin, and then Elliot, and then Kevin, if you're for feedback here. Robin?
Hey, David,
Yes.
after we do that, I'd like to hear those comments, but I'd like also to get, I don't want to lose track of it. I'd like Howard's feedback or answer to Debbie's question too before we leave the subject. But go ahead, but then I'd like to bring it back to Howard at some point.
Understood.
And David, this is Patrick. I can just weigh in real quick. Is that all right?
Yes, please.
I just wanted to touch on Debbie's point real quick. So I think the other point that Debbie raises, which I think is reasonable, is if we were shooting for a January 22 launch date for track 3, one, just how many track 2 practices will be ready, but 2, how many will see it as beneficial? I think that's one consideration that we all have to keep in the back of our minds is, unless the timetable for a vaccination, rapidly increases here, we could still be dealing with COVID in the spring of next year as the practices are trying to figure out how much more risk they are willing to assume. And while I recognize there are certain benefits of these population health-based payments, I think it's also just, thinking through what the risk tolerance is likely to be for potentially stretched primary care practices as they look forward, 6 months in advance of what 22 could potentially look like. So I think it's just, one thing to think of. And then the other thing about, CTOs being aggregators or how much risk to put on small practices versus large practices, I do think, there hasn't been a whole lot of discussion about kind of, minimum savings rates, minimum loss rates, all these different kind of actuarial things that could be put in place to kind of mitigate against some of the downside. And these types of models are put in place for MSSP. The HSCRC is doing it right now for their care transformation initiatives. So there are different ways to bake in kind of some statistical variation, particularly with low numbers of beneficiaries, to make sure that the risk isn't kind of unjustly measured. So I think there are ways we can think about it.
Yeah, very good point. So before we come back to Dr. Haft, as mentioned by Dr. Riedman, Kevin and Robin, any reactions to what you're hearing?
This is Kevin. My reaction would be that overall this effort, is got a lot going for it in terms of, a focus on cost and balancing that with quality. But the overriding concern, I think, from a beneficiary standpoint, has to do with access to care, and the concern would be that for smaller practices, you're putting them, if it's mandatory, you're putting them in a position of having to take on risk, and they just may not be able to handle it. So there's got to be some mechanism in place here to protect those practices, because they're the ones that are, meeting needs in out of the way parts of the state and health professional shortage areas and so forth. We've got to be careful with it.
Good point. Thank you very much. Robin, reaction?
Yeah, David, I would just add that it may be worthwhile thinking about disclosure and communication to the consumer about any risk-based arrangements. This is a very different arrangement than they're used to with their primary care practices. So I think it's worth thinking about how do we let them know in a way that's understandable.
Yeah, that's an interesting point. The RFA presents the opportunity for consumers to actually request to participate in this program, but you wonder what's actually required to be disclosed. It's an interesting point you make. Thank you. Dr. Haft, back to Dr. Riedman's point. Oh, and then Ben.
So do you want Ben or do you want?
Dr. Haft, and then followed by, or Ben, do you want to go for here?
So yeah, just a brief point. I don't know who made this point about, we do need to, I think, determine if CMMI is agnostic about about who holds the risk. It is attractive as we talk about trying to encourage very small practices into a very ambitious track 3 program, whether CMMI really has a perspective on how the risk is balanced between a CTO. We also need to consider, I think, that we're not altogether sure whether a CTO would be accepted into a track as part of a track 3 program. But it does seem as though a CTO, if we're talking about bringing very small practices into something that is very ambitious with regard to risk, would be a way to balance some of that off for practices who by themselves probably are not going to be altogether interested.
Understood. Thank you. Dr. Haft and Will?
Sure. So to the voluntary and a mandatory question, the model that we built based on 4 years of stakeholder input and a year of negotiations after that stakeholder input with our colleagues at CMMI to build this model. And this is the model that we presented to the broad primary care workforce across the state and was broadly accepted from virtually all of the primary care workforce as a model that we would have for the next 8 years. As we aim to change that to something else, it would be, I think, very duplicitous to say that what we told you we would do for the next 8 years is not what we're going to do now. And by the way, it's a mandatory change without great reason, and with some concern also that what we hoped to build and what we built was broad-based healthcare transformation across the state. If we walk that back and have pockets of healthcare transformation that are aligned with other things than where we started, we may lose more than what we gain. So I think that whether we call it mandatory and then make it with several tracks again, so that it's acceptable to the broad-based constituency we have, so we can preserve what we've built over the last year and a half, which is exceptional, doesn't happen anyplace else in the country, or whether we make it mandatory and narrow that scope, and is an important decision. There's also an important decision regarding risk, and something that came up repetitively as we built the original MDPCP model is that our Maryland Insurance Administration said that they would not allow a model to go forward if care providers took significant risk. That they could do that only if they had appropriate reserves. And I don't think that risk and reserve ratio would apply to most of our small practices. It might apply to large institutions and hospital-owned practices, but it would be at least an issue that we would have to raise again with our Maryland Insurance Administration. So risk is not a trivial matter.
Yeah, Alana, let's make sure we note the Maryland Insurance Administration question, the comment that Dr. Haft brought up. And then I think, Will, you were going to make a point.
Yeah, thank you, David. I guess I was going to respond in at least a little bit to Ben's previous comment. I think what we heard last week was that CMMI was interested in exploring the role of the CTOs under the track 3, and what that role would look like. I think if their role is not to help the small practices in this particular case, we would need to have a good justification for what then the CTO is supposed to be doing. And so I think that they were originally designed to help with the staffing of the care managers at small practices. And I think that if or CMMI is pushing for more risk, that's a natural area where we could at least explore creating a role for the CTOs. I think Howard raises a good point, but I do also think that there's a difference between a value-based payment arrangement where you have some amount of revenue at risk and actual insurance risk that somebody like CareFirst would hold. And, I don't know where those conversations are with MIA, but, I do think that the concept of having some amount of revenue at risk for value-based payment arrangement is very different from an insurance company being at risk for, sort of catastrophic claims that they would not be able to cover for an individual. And I'd be interested, I think, Stacia probably has a good perspective on both the value-based payment arrangement type of risk and the actual insurance risk.
Yeah, so Dr. Okiki and then Stacia.
Thank you. Alana, if you don't mind, could you scroll upwards a little bit? I'm looking at the blue column again. Yeah, keep going up. So right there highlighted in the availability of the SIP, and it's to be determined or rolled into MDPCP. And Dr. Howe said something that made me remember the comment I had for this particular point, which is we don't want to lose what we're trying to build. I think when reading the RFA and the way the SIP was structured, it kind of felt like there's that loss of continuity of care to have, a primary care practice that will sign up for just SIP, and there's this transition planning for warm handoffs back and forth. I think expanding on what we're doing now, which is a more comprehensive approach to primary care, be it a complex tiered patient or not, it's better. And I guess exploring how the CTOs can continue supporting along that line will be a more seamless approach to care. We've done a couple of programs at Hopkins and FQACs that had that, ambulatory intensive care practice, that we would take patients from their primary care and work with them for a couple of months and transition back. And sometimes some things get lost in the shuffle. So I think we have an opportunity to continue building on what we have. And I just wanted to, say I think it's better that we incorporate the SIP into the MDPCP as opposed to splitting it out.
So, Dr. Okiki, thank you. And Dr. Riedman, before we leave the comment made by Dr. Okiki, I think after the discussion around whether track 3 an optional or how we progress to it, you might want to come back to have the SIP conversation, which is included earlier on, but I yield. So, Stacia, you were going to make a comment?
I was just going to comment on Will's additions. There is absolutely a difference between having some performance risk and underwriting insurance risk. And nobody is suggesting here that primary care providers should be holding underwriting risk. Our hospitals don't hold underwriting risk in the state of Maryland. The original payer still holds all of that risk. And so this is a value-based payment arrangement. This is not a passing of underwriting risk. And I think it's really important as we talk about this that we use the right terms, because we will alarm other regulators. Even there's even all kinds of rules and physician incentive plans in Medicare Advantage. So let's be careful we're being discreet about how we talk about what risks.
Very good point. So Ben, comment?
Yeah, and the 2017 session of the legislature resolved this, I think, came out of Maryland START prohibitions, and I think we tried to align what we thought was going to happen with CMS at that time, and provided for some pretty broad exemptions to permit these types of arrangements to permit these arrangements from occurring. We can make a summary of that legislation, but I think it was resolved pretty clearly that these value-based programs were not insurance risk.
Yeah. Thank you. Dr. Pham and then Melanie. And she may be on mute or stepped away. So then Melanie, then Dr. Berenson.
Yeah, I just thought we should invite Scott Rose and Medicaid to weigh in on either the quality measure issue or the voluntary issue as they would like to weigh in.
Very good. So let's come back to these two folks, Dr. Berenson and Dr. Pham, and then we'll go on to Medicaid and Dr. Rose.
Yeah, I just wanted to agree completely with Stacia's comment about the fact that this is performance risk and not underwriting risk. It's not insurance risk. And very early on, I sort of tried to surface the issue that HCC is actually not the appropriate risk adjuster, but I realized how embedded that seems to be in this model. So I didn't push it, but in outer years, I think it might be quite reasonable to reconsider whether we're using the right risk adjusters for performance risk. The work that practices have to do rather than total health spending, which is what HCC is all about. So I just wanted to present a placeholder for that in subsequent years. I don't think it can be dealt with right now, but I do think it's a very valid point.
So, thank you, Dr. Pham, please.
Right, so I would completely agree with Bob and Sasha. I would also point out that there are an infinite number of ways to actually quantitatively define the performance risk. Right, so it can be a portion of the care management fee, it can be a subtraction from future years, it can be a carryover that they pay at the end of the program. There are a multitude of options that actually put people at ease.
Yeah, good point. Thank you. So, Laura, do you have comments from the Medicaid perspective you can share?
Hi, David. Thanks. I confess I'm a relative newcomer to the primary care first, so I've got a little reading up to do. I enjoy the discussion about measure alignment. I think there's a lot of opportunity there, but don't have any strong comments at this point. Just been interested in listening to what people have to say.
Very good. Thank you. Dr. Rose?
Yeah, what I expressed last week that I know Dr. Heft is looking into is the ability of the Medicaid behavioral health homes to become eligible to participate when we're ready, and how the elimination of track 1 is going to impact that. So that would be my larger concern. Quality measures as they stand seem fine. It would be that issue that is of importance. And I was satisfied with Dr. Haft's answer. I just wanted to reiterate that that's where my major question and concern is.
And thank you, Dr. Rose. Dr. Haft, can you just for the group, just sort of summarize the thinking on track 1?
So yes, on track 1, the expectation is that it was always a starter track for practices that would have an opportunity to develop all the care transformation requirements and move to a place where they were able to then go into the track 2 after a period of time. The track 2 then being where they had partial capitation and took on that partial capitation, and got more advanced payments. Track 1 was always meant to be a temporary track for practices, and as the program is has a defined period of 8 years, it had a period of planned obsolescence anyway. What we would suggest with CMMI is we would accelerate that obsolescence by a year or two, so that allow the track 2 to run out, track 1 rather, to run out in the next year or two rather than at the end of 5 years. So I think that would be the only difference. It's again, it has planned obsolescence in it anyway. So, and to Scott's point, we have CMMI has a specific bandwidth of things that they can take on during the course of a year in terms of programmatic change. The chronic health homes were given a second priority after FQHCs. And last year we worked with CM and CMMI and HRSA and the FQHCs to get FQHCs on board, so they'll be starting in the next program year. And chronic health homes were due to go on to be on the docket for this year for discussion. It's got pushed to the side, I think, substantially by this discussion. So it probably would again be following year, based on what we know about in terms of bandwidth for taking on new activities. So it's still on the docket. We've included it in the contract and in every discussion we have, but it's a matter of prioritizing CMMI's prioritization.
Understood. Thank you, Dr. Haft.
So a question, back to Dr. Reedman and maybe the others, I'm not hearing a good sense of a rate of progression or requirement for track 3. I'm hearing that it's established, but I couldn't get a sense, is there a progression in mind from the advisory council? I think we're hearing that it makes sense to move into track 3, but I don't hear that there's either a time limitation or an elimination of track 2, but yet a rational progression, whatever that may look like, into track 3. And I would ask Dr. Reedman if that's what you're hearing, or is my interpretation slightly different than the rest?
No, I agree, Dave. I was going to come up with the same comment just now before you brought that up. That what I'm hearing is that, or at least from my primary care standpoint, is that I don't hear anybody saying that we feel like we should do track 3 mandatory year 1. That eventually it should be mandatory potentially, and that there needs to be a phase in whether the groups are ready to do it and willing to do it initially, but there should be some phase in. And I'm not the expert in this area, but how that phase in goes, whether it's increasing percentages up and down or increasing risk, I think that's certainly from my standpoint as a primary care physician, the better option. I think the other thing that kind of falls into this conversation as a primary care perspective is that we're having difficulty recruiting primary care physicians. There was a really good article that someone had sent out recently about the number of primary care groups and physicians that folded under COVID because their margins are slim, and the business that they lost for COVID, and people that have retired early because of COVID and all. And so primary care is becoming critical to find primary care physicians. And we've had this come up with, we do training for residents and med students in our offices. And, questions come up all the time. And one of them is, the administrative burden, the paperwork. But one brought up a comment recently that, so when we were talking about MDPC and risk and all, was that, so if I go into orthopedics, I have no risk. I make 5 to 6 times what you do as a primary care physician, and I don't have to do the administrative stuff, but also I don't have the risk. So what it brought to mind was, and I'm not sure how this falls into our conversation, I think it's an important point that I feel necessary to get across as a primary care physician, but any risk that if you put the primary care physicians on at risk for a mandatory, in particular, track 3, before or at the same time that you don't put the specialist at some kind of risk, that's a setup for, if nothing else, difficulty in recruiting. But I think that and it doesn't fall into this committee necessarily, but it's a comment that I think needs to be made, that the specialists also need to somehow have some risk. And we haven't seen that in primary care. I know that the PCMH program is starting to do that after, I guess it's been almost 8-9 years. They're starting to put in some of the specialists at risk, but so far there's not been any. The total cost of care and the risk has been put on the primary care physicians. I think it's important that they be put on, and there be some conversation about how that plays into the other specialties. Having said that, again, I think it's an important point when we talk about making track 3 mandatory on the primary care physicians. So I'll leave my my editorial comments at that, and I'll open it up for conversation. I would like to, though, to get a better sense from the committee. There's been some great points, but whether we're correct in saying that we don't feel like it needs to be mandatory year 1, maybe at some point in the future, and then we come up with some timeline and some kind of phase in for that.
Thank you, Debbie. And then I would like to invite Brett in. So Debbie.
Yeah, I just want to clarify what we mean when we say it's mandatory. Mandatory in order to be in the program, correct? We're not saying that this would be something that would require all primary care providers to be at risk. I just want to clarify that because we never really defined what mandatory means.
So, Dr. Happ and Dr. Reedman?
Yeah, I think that's the intent, Deb, is that it would be mandatory. If you wanted to stay in the program, you would need to move to this specific track 3. There would not be any other option besides that. So, and then if not that, then it would be going back to fee for service and MIPS.
Right. So that gets at the point somebody made earlier in that we want to make sure we're moving forward and not backward. So when we do talk about that, if it's mandated and there's not a readiness, we could then have a great exodus from the program and not achieve our goals, I guess is what I see playing out.
I think it's better than an even bet that we'd have a great exodus. Yes.
Yeah, and I think what Brett, before you jump in, I think what Dr. Reedman is suggesting is that there may be a progression plan, but it's certainly not in year one that there's a requirement. I think that's what I heard Dr. Reedman say. If that's correct, then Brett, perhaps you, and then Stacia.
Sorry about that. I don't have any additional comments. We're balancing this. I say that we're balancing this, you know, with what's the appropriate level of risk, but we don't want to make that level of high. We will encourage people to look away from it. So, I mean, it's a difficult balance to figure that out. But I don't have a proposal.
Understood. Thank you, Stacia, and then.
Yeah, I was just going to add, I haven't at any point in time heard anybody talking about track 3 being mandatory in year one. I think that there is a rational argument to be made, though, that why would we let practices stay on track 2 indefinitely? Like maybe you can only be in track 1 for so many years, and you can only be in track 2 for so many years before you need to progress. Because otherwise, what would be the motivation to progress, right?
Yeah, interesting. Dr. Haff, can you, any response to that?
Yeah, I think that, you know, that we could make something that's mandatory with a little bit of thought, but it allows for, you know, a variety of different levels of participation, still with progression. And I think that the issue of progression is, you know, if we're talking about progressive primary care risk, there's absolutely no limit to that. I think, you know, primary care, we all know, is at the bottom of the scale in terms of income, in terms of revenue production, and has a limited ability to control costs. So that I think there needs to be a progression, but it's not an infinite progression, and it should allow flexibility so that practices that are in fact doing a good job, you know, perhaps, you know, reducing avoidable utilization, has high quality, but are not tolerant of risk. You know, so I think of so many solo practices that if they lost 10% of their income, would have to, you know, let one of their 2 staff members go. But they provide wonderful care to the patients that have been dedicated with them a long time. We don't want to create that situation. We want to be able to keep what we have, but make appropriate accountability. I like accountability better than risk. I think risk really is first, it was good to know that, Ben, that we resolved the insurance risk issue. I somehow I've lost track of that, but let's take that completely off the table. But the financial risk issue for small practices is still an issue that we need to we'll need to attend to, make sure that we have a system that provides the ability to provide the highest level of care for everybody across the state, advanced primary care, but still allows that kind of flexibility to let small and medium and large practices in, all meeting their, you know, what their necessary financial benchmarks for survivability and success. We do want, you know, frankly, want them to be more than just barely survive. That is not I wouldn't want to sell a program to someone who says you can barely survive with this. We want to make them thrive. I think that's the goal. And at the same time, be accountable.
Thank you. So we'll do Melanie, Kevin, and then Dr. Okiki.
I just wanted to see if Dr. Berkowitz wanted to weigh in on anything that we've discussed to this point. I believe he's online.
Dr. Berkowitz?
Yeah, thank you for your comments, and sorry I've been dropping in and off. But I think to the point that was just made, it would be important to allow flexibility. I think this was the first meeting, if I'm recalling, where it sounded like a mandatory progression to track 3 was stated explicitly, even if there wasn't a particular timeline. And so if we're phasing out track 1, track 2 continues, and we consider over time what is an appropriate timeline, what are the circumstances, and what is the input that needs to be provided by stakeholders in order to feel comfortable with what track 3 will bring for all those different constituencies. And I think that that can be done, but I think we need to be thoughtful about it, and similar to what we're doing now and trying not to rush something for next week, have the careful development that would go into building out a program that will ensure continued success for all the stakeholders.
Understood. Thank you. So Kevin.
Just a semantic point, really. I mean, as I listen to the conversation, it would seem like we could almost picture a use of a term, a theme for this effort. I mean, we're all very much trying to feel our way along here. There was talk earlier about how the quality measures will need to be improved over time. Dr. Reedman's point about, you know, what can happen for these smaller practices. Do they see a path forward to participate in this? Anyway, so the word I'm thinking of here is learning. That along the way, we are all going to be learning how this program can evolve, how it can improve. And so a word like mandatory really doesn't capture what's going on here or what will go on. Rather, it's going to be a learning process and a gradual sort of evolution and allowance of and decisions made on the part of individual practices about whether they want to participate or not. So I would not like to see us adopt use a word like mandatory. I'd rather see a word like learning. That's all.
Okay, more of a progression, I think I hear you saying. So Dr. Okiki, and then I think Will, did you have a point? Okay.
A question.
Yes.
So my question, I guess I'll target this to Dr. Haft, and I know the total cost of care work group is also looking at this in a more holistic way for the state of Maryland. And as we start talking about track 3, we have by this time seen our primary care practices begin to advance through track 1 and track 2 and making some advancement. If we truly believe that the total cost of care problem we're trying to address cannot be fully accomplished without pulling in the specialty providers, at what point do they come in and when does that alignment begin? Because my thought would be, to Dr. Ridman's point, if we already move into track 3 for primary care providers, is this a good now track 1 for specialty care to come in, and how is that being looked at from the total cost of care work group, and how does this all align?
So Dr. Haft, and that's sort of what Dr. Reedman was asking the question, but Dr. Haft and then perhaps Will may have an answer for us.
Yeah, I think probably Will have more of the answers regarding the, particularly the hospital-based specialists. But I think kind of the movement there is more probably along the lines of the bundles and other kind of voluntary participation in those models for the specialists. I know that the PCMH program at Care First is devised and is rolling out another unique way to get specialists, quote unquote, skin in the game. And I think that's something that we would, welcome as part of MDPCP and its future. This is something that will require a lot, again, of stakeholder work. One lesson we've all learned is that you got the best program that you can conceive of, most brilliantly constructed on paper, but if the stakeholders don't either understand it or like it, it's just a program on paper, and it won't have any effect on total cost of care or patient outcomes or anything else. So that's an important consideration as we do this. And I think, as Kevin pointed out, it's really about it, over the long haul. We need to get no matter what we do here, we'll need to spend a considerable amount of time educating and engaging and getting stakeholder buy-in on it. Usually it goes the other way. You get stakeholder buy-in first and then build it. But in this situation, we're doing that backwards. So it'll take probably a little longer to get more stakeholder buy-in.
Okay, thank you. Will.
Yeah, so I guess I have 2 comments, one on primary care and total cost of care, and then one on the specialty models. On the first point, I guess I'm a little concerned. I think that when we look at the literature on ACOs and other value-based payment models happening nationally, I think the literature there suggests that physician primary care-led ACO models work better than the larger system ones. They are better able to control the total cost of care and improve quality. And so I don't agree with Dr. Half's assertion, right, that the primary care has very little ability to influence the overall total cost of care, utilization, or quality measures. And I guess I'm also concerned because the state of Maryland, when we were going through the clearance process on the total cost of care model, I think justified what are rather large investments in MDPCP by saying we believe that primary care is where we have to put a fairly large investment in order to be able to be successful at reducing the total cost of care and taking out unnecessary utilization. So I think it's important to continue to represent MDPCP as a sort of core total cost of care management strategy, since that's what I think CMMI justified the investment on and will continue to evaluate the model on.
Just a point of what I think the primary care can influence utilization significantly. Costs of care, as we know, in Maryland are not directly related to utilization. So just before we go too far down that path, I'm very strongly supportive of primary care being able to help make utilization the right care at the right place for the right person. It just doesn't necessarily translate to total cost of care.
So I think we'd be happy to have a technical discussion there. I think it clearly does translate to total cost of care, right? I mean, the claims are still paid by the beneficiary that goes to the hospital, or the payer for that beneficiary that goes to the hospital. So you do see total cost of care savings at that beneficiary level when you get utilization reduction. But I think we're happy to have an offline, sort of technical session if you'd like, Howard. Sure. I think on the specialists, we are working on developing some specialty models. We've been working on a program called Equip that would include some specialists and include total cost of care accountability for them. So, those conversations are ongoing, but it is a long process, and we're sort of slogging through that. But maybe Gene or some others would be able to talk more about that.
Okay, so
Will, I'm sorry. So, Will, I just have to make this comment. So, primary care has a week to make a decision, but we've had years to help the specialist make a decision. We still haven't done anything with the specialist. I guess that's one of the pet peeves, I guess, of the program is I keep hearing about voluntary programs for specialists moving that way, and we're coming up with ideas. And this isn't going to be really approved our committee, but when I hear things that we're working on specialists and doing some programs, I'm not sure why there's been such a delay in getting the specialists involved in what the primary care physicians have been involved in for years. And I'm not sure we need to have a conversation tonight, but I couldn't let that go without making that comment. Sorry.
Yeah, so I definitely think it's a good point. When we have those conversations about specialists, I think we're talking about moving risk and accountability to those specialists. We're not talking about making the same sort of large investments that CMS made in the primary care setting. And so I would view the focus on primary care first as a belief in the importance of primary care, and then specialists obviously are also very important, but they're not sort of the first touch that a patient gets, and therefore the critical locus to reducing total cost of care. And so, I think that if CMS or HSCRC or someone were designing a strategy, where do you want to get the most bang for your buck? You start with primary care, and then you try to expand into the specialty practices, and that's a reflection of the importance that primary care has as the gatekeeper.
Thanks, Paul. David, we've got, I know Stacy wants to have a comment. I'm not sure there's anybody else right this second. We've got about 5 minutes to wrap up. So I'm going to get a couple more comments and we'll summarize. So Stacy, you had a comment I saw?
Sure. I would just actually tag on to what Will said, because I think your question is a fair question. Nobody in any of the models I'm seeing is suggesting making population-based payments to specialists. It's all about how do you compare episodes of care, procedure-bound episodes of care, from time period A to time period B, so you get those more and more efficient, and that those episodes on a PMPM basis, they begin to make different choices about things like implantables, things like devices, things like courses of PT treatment post-operatively, but they're very bound to procedures or kinds of care episodes, as opposed to a longitudinal care of the patient over a period of time that's relationship bound. So while I hear your concern about, you know, why is that part taking so long, it's also because they're all doing something very different. And so you have to actually design that around the kinds of care those specialists are rendering. Orthopods, GI specialists, maternity episodes, those are all very clear to define. Lots of it isn't.
So,
Thank you.
Dr. Riedman, I would note before I hand it back over to you that in this category, we still probably have a bit more discussion around the CTOs and in track 3, what does that mean? And then the SIP population to pick up on in our next conversation. So with that, I would yield back to you, and then we can bring it to a closure based upon your comments.
Sure. So thanks, David. I really appreciate the conversation. I think it was excellent. We got through a big chunk of this. The rest of the items I think we'll be able to get through very rapidly. You guys can all read them. You guys, I've been in the north too long. You all could read them and look at them and all before our next meeting. But I think we have to be able to get through that and the rest of this item pretty quickly and finish up with our template next week. I think in the meantime, we'll work with the committee and with Dr. Haft and all to talk with what we can do about postponing our deadline from next week. And as we talked about earlier in the meeting, and I'd still like to shoot for, again, I think we're already on the books for next Tuesday, keep our Tuesdays going, and we'll let y'all know if we have any updates sooner than that. So Melanie, you had a comment?
Oh, I was just going to say, you know, we're going to post this sheet that we've been working on. So that'll be posted onto the MHCC website at some point before the next meeting. We also post a meeting summary there. And to Dr. Riedman's point, we have meetings scheduled for the next few Tuesday nights. So David, I don't know if you want to clarify or expand on that, but.
No, so operationally, I think we're all set, Melanie. Did we miss anything?
No, those were the 3 points that we were having them on the website. So, and the emails that we send around, it will point people to where we were.
And I think Dr. Berenson, did you want to make a comment, or I couldn't tell if
I was just stretching. I'm sorry.
So before we go back to our leadership, Ben, any comments for us as closing? And I think you're muted.
Ben, you're muted, Ben.
Oh, now we lost him.
Okay. Well, Howard, do you have anything you want to say before we wrap up, Howard?
So, Michael, just only to ask you and David to give me a sense of, did you want us to read the PMO to reach back out to CMMI with the state of where we are now and ask them for further extension?
I think so. I think we're all. I think everybody's in agreement that we've had some great conversations, but we need to double back and really think about some of these items before we come up with a more concise list. That's especially for this important these important decisions. I think, as we talked about earlier in the meeting, absolutely. I think if we can get a time delay on this, whether it's weeks to months to a year, I think we really should ask for that. I think this is a too important an issue to push through and to rush through.
Okay.
Yeah, and if Howard, if it's helpful, the three of us, we can talk offline if that works. If you need a better sense of steering, I'm happy to do that. And I think Ben joined us back. So are you there? Melanie, do you see him? Okay.
Yeah, I'm here.
Yeah.
Okay.
just a couple research assistant duties that I'll be happy to provide. One is to provide the synopsis of House Bill 403 that addressed the issues of value-based payment in the private sector, which was resolved in 2017. I'm not going to send you the bill. I'm going to send you the synopsis and a link to the bill if you're that curious on how sausage is made in the Maryland legislature. But and secondly, the Healthcare Commission staff, following the lines of what some other states have done, has tried to estimate the share of total healthcare spending that can be attributed to primary care. We're using the methodology that was referenced originally in a Milbank piece from a couple of years ago. And we use the code that was developed by colleagues at RAND. I'll send you copies of both those pieces. I think our finding is that, like many states, primary care spending hovers around 4.5% or 5% on average. This is for the private sector. We're going to follow up with another study on Medicare and Medicaid in the near future.
Okay, thank you, Ben. Dr. Reed.
No, I think we're a minute over, and I think we can conclude hopefully close to time on time, unless someone else has a burning question. I think we'll talk to everybody next Tuesday.
Thanks everyone for your time. Great conversation.
Bye bye.